You're listening to the 40 Fit Radio podcast, dedicated to the 40-plus community. Join us as we discuss the truth about fitness and health using science, reason, and the experiences of our host and content experts. Welcome to the 40 Fit Nation. Hey, welcome back to 40 Fit Radio, and welcome back to the 40 Fit Nation. I'm here in our studios live from Keller, Texas, and I've got Coach Trent here with me.
Yo.
And we have been talking about, actually, we had talked previously in a podcast that we did on shoulders and kind of exercise modifications, programming modifications, and we were going to do other body areas. So today we're going to talk about the low back, the lumbosacral region, also known as the lumbar area, and the sacral area, also known as the low back. So we're going to talk about that today.
So when Sir Mix-a-Lot says "baby got back," is that what he's referring to?
I don't know what that means.
Or is there something else?
I am too uncool.
That's like your era, man.
Yeah, I know.
That was 30 years ago.
Yeah, I was in my 20s, so thanks for reminding me, Trent. You suck. We were actually talking about several clients that we have right now that need either some programming modifications or some change in exercise selection or an exam to take a look at things. But so we've been discussing this. It's been on our minds. I train around back challenges all the time. My back, and I'll just say, so some of you guys know I had 4 back surgeries in the same calendar year. About, I think it'll be 4 years ago this December, if I have my dates right. I think that's
2016.
Right. Yeah.
I think it was right before I met you, or maybe around the time.
Yeah,
right after.
I think that's about right. And so I had 3 laminectomies, and then I finally had a fusion at that level. Just had a bad level spondylolisthesis. I don't necessarily recommend surgery for people. I don't think surgery is the answer to the majority of problems. Sometimes in structurally unsound or structurally unstable segments, spine surgery is needed, and you got to get done what you got to get done, unfortunately. But always seek guidance, get first, second opinions, seeking experts, information. If anyone ever has a question about pursuing back surgery, looking at a spine surgeon, finding out what to do with back pain, you can always email me, info@40fit.com, or you can email me, 40fit.com email works, or you can message us on Instagram or Facebook or whatever. But we're going to talk about back pain and how we might modify training and what other exercise selection or programming changes we would make with someone with back pain. Now, first, let me preface this conversation by saying this. We cannot do a 20-minute podcast and cover every single thing that needs to be known about back pain and training. It's just not possible. We couldn't do a 20-hour podcast and do that. Back pain, I was telling a client yesterday, this is really funny. A close friend of mine came to me. What were you going to say?
Well, I was going to say, we did
of your lips.
We did like a 4-part series on lower back pain.
Yeah.
If you go back to, I don't know, when that was the 30s,
great
40s.
Series.
Yeah, it was about a year ago, I guess.
What a bunch of knowledge.
Yeah, we dropped some knowledge bombs on you. But yeah, we did 4 podcasts, and we really just hit the tip of the iceberg there. So if you want the deep dive, go back and listen to those. But today is going to be focused on practical applications for, what are you going to do with your training when you run into a roadblock due to back pain?
Well, and so I had 2 clinical visits recently. I had one yesterday from a close friend who has a sequestered, which means he's got a disc. It's in pretty bad shape. It's got chunks that are basically extruded and fallen off of the disc or blown out of the disc, and it's pushing on the nerve root, or appears to be pushing on the nerve root in an MRI and a CT scan. And he's had a couple of what we call buckling events. Buckling events are events where you go to pick up something, you go to bend over, you go to do something, and your back just gives out. You feel like you cannot use your back musculature, and it locks up on you. You can't stand back up many times. You get totally locked. And what happens is that is a protective guarding response to many times a mechanical problem or some type of compression, injury, lesion, whatever, the straw that broke this camel's back type of thing. And it might be a very minor movement. He went over to pick up, I think, a shoe and put a shoe on, and his back just totally locked up on him. Severe centralized low back pain. And so he saw me yesterday in clinic, and we were talking, and he said, so wait a second, I've got this bad disc. It is what it is. And how is physical therapy? I mean, we're not getting rid of that. And I said, no, we're not getting rid of that more than likely with physical therapy. Your disc is injured. Your disc is mechanically altered in regards to its dynamics and its ability to act as a shock absorber and to create space and do all the things that discs do. Discs sit in between the vertebral bodies, the bony bodies, the segments of your spine. And they act as shock absorbers, and they also allow for movement, mobility, and create space where they're supposed to, so forth and so on. And so he said, so how is physical therapy going to help me? And I said, well, you know what the strange thing is that there have been studies shown where we have had a patient that has come in with severe nerve root pain down the leg, hard neuroscience, and they had a large disc herniation that was extruded or sequestered and was out pushing into the nerve root. And they did physical therapy, they did oral steroids, then maybe an epidural or two, and then physical therapy. And within 8 to 12 weeks, they were rocking and rolling and near pain-free with no referral pain. And they did another MRI on him. And the disc matter, the extruded disc fragment, was in the exact same spot. It was still pressing on the nerve root, and all the mechanical pathology or the pathology that the injury that was there before is still there.
Yeah,
it's not like a skin lesion that heals up and it goes away, and you go, oh, there's no scab there anymore. There's just a little scar. It's healed. It's done. So in that case, he was like, I don't get that. What's the deal then? He said, I said, you know what? That's a great question. We don't know.
Yeah,
we don't know. Back pain, back pathology, why we hurt in the back is a very complicated discussion topic because is so much going on around the spine and around the spinal column and around the spinal tracts and around the neurological system. And also then we have to add human behavior into that.
Right.
We have to add the mind and the fact that we perceive pain in our mind. And then it gets bathed by our limbic system, our emotional system. And so you got to add that in there too.
It's a complex. Yes. Yeah, we talked about that in part 2 of the lower back series, the biopsychosocial model of pain. And I think a lot of people that don't know otherwise think of pain in purely mechanical, like structural terms, like X is not right. It's broken or it's bent or whatever. You know, you've got a herniated disc or extrusion, whatever the mechanical problem is, ergo that's causing the pain. It's like, well, maybe that's some of it, but it's not all of it. There's often a feedback loop through your, as it's mediated through your brain and your emotional response.
People can have pain memory and they can have an emotional response, behavioral response to pain. And so then I'll go into this next discussion. Then I saw another patient earlier last week who flew in from another state to see me. I will not mention their name. And that person had, I think, a 2-level fusion, a disc replacement, had some knee problems too. But their spouse had heard a podcast with me on Brett McKay's podcast, Art of Manliness. And so their spouse decided to seek me out and then get a visit with her. And so when they flew in, I did an initial physical therapy exam on the person. And what I found basically was this: the patient was just stuck. They were stuck with fear avoidance behavior, and they were stuck psychologically and intellectually. And this is a smart person, PhD. They were stuck just trying to figure out how to digest where to go from there. So many times when we have these low back pain issues or low back pain injuries with actual pathology that requires medical intervention, even surgery, afterwards, we're kind of left hanging because we really don't know what can we do, what can we not do. And I basically just gave her permission with a certain amount of administration and a certain amount of, I guess you would say, not caution, but just awareness that, I do not see you having restrictions. We need to start, and we need to start lifting. And that's what we did. We did a barbell startup program with her. Then I did one physical therapy session first. Then we did a barbell startup program later that evening. Then we set some programming. Then I hooked her up with a great online physical therapist coach friend of mine, Will Morris, because I'm not taking any more online clients right now, at least. And he is going to work with her on a one-on-one basis, on a weekly basis with her programming and understanding her pathology and understanding her medical history, which would be a perfect balance and blend. And then we did another session on Friday where we just, then we did another session on Friday where we went back over some of the movements and just talked principles. But ultimately, at the end of the day, I told her, I said, what I am doing for you this week is giving you permission to move forward.
Yeah.
What I am doing with you this week is not necessarily going to treat you. I am creating a path for you to follow so that you know that there is some level of intellect and awareness and experience in knowing what direction to go into, and you have some faith and hope, and you can move forward. And I said, I have no doubt that in 6 months to a year, you're going to be crushing this thing.
Yeah.
And she got emotional,
Well, I bet. I mean, it's, I think you've talked about this. Like, you kind of went through a similar experience where you knew intellectually what to do to start rehabbing your back after all the surgeries, but in the moment, day to day as you're training, you're probably not seeing that. You know it's going to come, but you have to train. You have to start training and get the process going before you're going to see any results.
Yeah,
and it might be a while, and that's scary.
Yeah,
that is scary.
Yeah, I think it is, and I think when you think about it structurally, let's say someone's had a lumbar fusion, and everything else looks relatively healthy in their spine. Once that fusion is healed and they are out of the precautionary post-op rehabilitation time frame, and we've got good bone stock, we've got good purchase of the hardware into the bone, and the segment's stable. I mean, my philosophy as a therapist, and maybe some of my other therapy, my other doctor friends would disagree with me here, but my philosophy is the only thing I don't want that person doing a lot of is a lot of ballistic, high-speed movements with a lot of bouncing around and I won't say like bouncing around, but
maybe they're not going to be Olympic weightlifters after that.
Well, I don't know.
Maybe.
I don't even know about that. I would say that's a controlled motion.
Okay.
So,
yeah.
I mean, really in my mind here, what I'm really saying is I don't know if I would give them any restrictions other than I don't like things like toes to bars, burpees for those clients,
sure,
knees to elbows, a lot of flexion and extension where there's a lot of movement above and below, especially if they have a floating fusion, where they can get what we call adjacent segment disease. So where they wear out the other parts because mechanically the middle part's not moving the same. And so, but otherwise, if it's a low lumbar fusion, I don't put any restrictions on them. I let them do. I mean, dude, I ride horses, which I guess is bouncing in high speed. I work on our cattle. I lift. I would snow ski. I would water ski. I've wakeboarded. I mean, I've done just about everything.
Carried heavy
standing
packs.
back flips. Yeah, elk hunted. So now I'm not saying I'm pain free, but so we have this component of behavioral intervention that has to happen during training, and then also some actual modifications in exercise selection and programming. So let's say someone comes to us and they have an acute lumbar sprain and strain, then that's we're talking about a muscular injury there. That's a very easy thing to do. There's a slight deload that occurs. If they have pain, if trying to pull off the floor, I might do some rack pulls for a very short time frame just to limit the pain at the very bottom of the pool. The squat, I mean, I'm not going to do a whole lot.
Right. Yeah, so maybe if we logically analyze the situation, I think one thing that's really helpful anytime you encounter pain that is new when you're training is to observe it first. Keep doing what you're doing. If you observe it during the warm-ups, I always say, like, okay, if somebody's starting to have a new pain that occurs during warm-ups, say, okay, where's the pain? Can you describe it to me? Let's do your next warm-up, and maybe if it was real bad, well, let's repeat that warm-up set and just observe what's happening right now.
Yeah.
And then we're like, okay, is that better or worse? And well, maybe the same. So, okay, well, let's try the next warm-up.
Right.
And just slowly walk through whatever you were already planning to do.
Yep.
And just observe and be specific with what you're experiencing. Because sometimes, I mean, shoot, I'm 31. I'm still young.
Yep.
And I have some days I go into squat and my left knee just hurts for no reason. Yeah. And then the next time I come in squat, it's gone. Yeah. So sometimes that stuff happens. It's just being human, right? But
you can't overanalyze that stuff either.
That's right.
You're really looking for trends and patterns.
That's right.
Many times.
Exactly. So that's why observation is usually my first thing. It's like, let's just figure out what's going on.
Yeah.
Note it, and then just keep training.
Right.
And then if you start to see a pattern over time, that's when you might start to address it. So,
I mean, I've had lifters and patients, go in and they start squatting, and their back feels a little wonky, and so they just stop. I'm not recommending that.
Right.
I'm recommending that you maybe do a video review of a warm-up, look at your form, make sure your form's dialed in, make sure you're keeping a nice tight back in the bottom or driving through the squat with your hips, that you're not getting too vertical. I want you to be horizontal. I want you to turn those back musculature and hips on,
right,
and those hamstrings on for stabilization of the pelvis. So maybe you're soft in the abdominal area. A lot of my squatters sometimes, or some of the squatters will actually just kind of push through their belt, and they're just kind of over sagging in their abdominal area, and they're using the belt. I want them to actually tighten their abdominal wall as they squat to create a stability of the spine.
Or maybe you get a little lazy and you get a little loose at the bottom instead of staying tight.
Yeah, you get a little bit of lumbar
lift.
flexion at the bottom.
So observing, just simply write, and maybe you just write it down in your notebook. Like observe the pain, note it, try to be as specific as you can, and that's going to give you a hint if that becomes a pattern, if that becomes a trend, that's going to give you a hint as to what you will do to adjust your training if that's what's needed. So you just mentioned a good one. If you're experiencing pain off the floor on a deadlift in your lower back, then maybe changing the range of motion. Can we shorten the range of motion and still make your back work, but do a little bit less work in the area where it's the most painful?
See if we can gradually work our way back down.
Work the way back down, exactly. And that's the way I would approach that rack pull. That seems to work pretty well for me. Is I will start it just below the kneecap, rack pull there a few workouts as needed, and once that's feeling good, move it down to mid shin.
Yeah.
And then rack pull there a few workouts, and then back to the floor and see how that goes.
Yeah, and I also like to, let's say someone comes in with a lumbar strain, or they strain their back while lifting, they strain their back while working in their garden or whatever, doing yard work. It doesn't matter. And they come in to lift, well, then we're going to go to their regularly scheduled program. We're going to go to their regularly scheduled program. We're going to go through the warm-ups like you said. We're going to see how they feel. If I need to, I can do a slight deload with them. And I might try to hit a top heavier set, and I might try to increase the volume a little bit in the deadlift because I'm trying to do rehabilitation type activity. So I might try to do a top heavier set to stimulate growth and healing of the muscle and stimulate those good hormones, those good healing chemicals in the area that the immune system provides when we provide stress. And then I might do a couple of back off sets at like 2 sets of 3 with a little bit lighter weight just to get some blood flow in that area.
Yeah.
And then I might also throw some accessory exercises in there like good mornings, Romanian deadlifts. Those are all going to be done relatively light.
Yeah.
They're not big strength movements. They're more control movements and just work for the lumbar and hip region.
Yeah.
And then I might also throw some, I like to do bench bridges where they're lying on a bench with their shoulders across the horizontal side of the bench, and I might put a weight on their stomach or waist, and I make them go all the way down and then all the way back up.
Touch their butt to the floor and then shove their hips through.
Yeah, and then go into neutral
to make a table.
Right,
sort of.
and then go. Yeah. Exactly. Go up about as flat as the bench, basically. If their shank height is high enough to allow that kind of level, and then I also, when they get up to the top there, I might have them do what I call knee extensions or leg outs where they're holding that weight or just their body weight, and they straighten one leg out and support it with the other leg. Get that good kinesthetic awareness of the lumbar musculature. And we're just basically flushing those muscles with work and blood.
Yeah.
So I like to do that too. I like to do planks, front planks and side planks. I like to do them weighted, unweighted. I like, Will Morris's movement, the cocaine deadlifts, which is, basically kind of I won't say it's a touch and go, but it's a relatively stiff-legged deadlift from the top, and you come down to right before the floor and you change direction.
Right,
okay?
right.
So basically what you're getting is a lot of isometric support and control of the lumbar region while you're getting some really good eccentric firing of the hamstrings and the glutes in kind of a protected range too. And those are done relatively heavy too sometimes.
Right. Yeah, once you learn how to control that movement, load them up. Yeah, I've learned from you that often pain in the lower back that's occurring during the deadlift and the squat is the result of maybe underdeveloped posterior chain, underdeveloped hamstrings and glutes. And it usually goes hand in hand with a technique error as well. And I want to save that. We'll touch on that in just a second here. But sometimes just doing that extra work to stretch and strengthen the hamstrings in the lower back can be really useful. And you mentioned most of the ones that I go to, the good morning,
right?
The anything that's going to force you to keep your hamstrings and your glutes, put them under load, and then stretch eccentrically
dynamic stretch.
Or isometrically.
Yeah, so, stretch under load or dynamic stretch.
That's right, exactly. Yeah. And you're doing it with a lighter weight than you would say a deadlift, so you're able to do it in a more controlled fashion and really focus on that one area. So in terms of technique, I often see people who will imagine they have a mental model of deadlifting with their lower back as the sort of hinge point, as opposed to feeling tension in their hips, which the sensation is kind of where your hamstring and your butt meet in the back. You want to feel the tension in that
pressure
area
right there.
You feel that pressure
right on your glutes,
and that's how you know that you're actually using your hamstrings and your glute, that posterior chain, in the squat and in the deadlift. And so if they're just not getting it with the barbell movement, then we can do something like a good morning where it's much lighter and they can just focus on that sensation. I also like the barbell row. Is good for that too.
Good isometric. It's that's really good for proprioception and awareness of lumbar neutral or slight extension in the lumbar spine.
Because you want to set your back every rep.
Right. You flex. I make my lifters flex and then reset every rep because I want them to feel the range of motion of contraction of the spine. It's not a huge range of motion. The problem is people get fatigued over rep sets. What happens is they think they're contracting hard and they're contracting a little bit less in extension each rep.
Right.
So we got to get them to focus on really extending that back into neutral or just a little past neutral sometimes based on their mechanics.
Exactly. And often with that fatigue, people will start to drop their hips to get their back tight. Yeah. And then they're relaxing their hamstrings. So doing these accessory movements to focus on that tightness in the hamstring glute tie-in, if you will, can be really helpful.
A lot of the accessory or, we call them accessory exercises or assistive exercises. They're a little different in nomenclature, but a lot of those exercises are great for proprioceptive awareness of the lumbar spine. Yeah. Where is the lumbar spine?
Right.
And, in our starting strength seminars, we always do that pelvic anterior tilt, posterior tilt to get people to understand. And guys are terrible, man. They don't know. Women are a lot better at getting that pelvis into an anterior or an arched back, kind of what we would call a sway back position.
Right.
And a male is much, number one, they don't have as much mobility. And number two, they're just not used to doing that kind of position, And so when we do the seminar, it's classical that a lot of males, especially older males, they can't get their back into lumbar neutral or slight extension without some type of tactile cue or positional cue or verbal or visual cue. And so I like the assistive exercises and the accessory exercises because I can watch their back angle and ask them, okay, is your back in extension right now? They could be in a plank right now. And I can say, okay, are you overextended, underextended? Are you flexed? No, I'm neutral. Okay, good. Or have them do hip bridges. Are you keeping your back in extension? Or are you flexing, extending your back? And are you really pivoting from the shoulders and hips where I want you to?
Right.
And your back is staying like a 2x4, basically.
Yeah.
So I like those exercises. I also like you said, the Romanian deadlifts and the good mornings, because I can really work. On a good morning, you're supposed to flex at the hips, the knees, a soft bend at the knees.
Just a little bit.
The bar is on your back versus on a Romanian deadlift, the bar is in your hands. They're a very similar movement. They both start from the top. But one, on the Romanian deadlift, the bar is in the hands. On good mornings, if you're using a bar, it's on your back. And so as they bend over at the hip and hinge at the hip, the back should be perfectly straight. And I tell them, go until you feel tension in your hamstrings and you feel like you're about to lose your back position. And 9 times out of 10, guys will go too far. Women will generally go to about right where they need to go to.
Yeah.
But 9 times out of 10, guys will go too far and they'll lose a little bit of back tightness before they recognize that they've lost that tightness.
Right.
That's a problem. They need to be able to perceive that their back has lost extension earlier than that. And so that's why I use that exercise, because it's great training, great for the hamstrings, great for eccentric control and isometric control, the back musculature.
Yeah, and it's interesting. I think I've seen this issue pop up more with lifters that have a long torso and shorter legs. And I think it's because in everyday life, when they're moving stuff around, they're picking stuff off the ground, they naturally have a more vertical back angle in everything they do. And so they may have been able to, especially the bigger guys they're heavier, they may have been able to just use their body weight in that more vertical back angle as a counterweight. And they've just been lifting with their lower back, it just hinging at the lower back their whole life.
Right.
And as a result, they don't develop that posterior chain. So when they come in to deadlift and squat, they don't have the proprioception like we just talked about.
Right.
And they may also just lack strength.
Right.
Like their upper back has the strength, their quadriceps have the strength, but they're missing that posterior chain and lower back strength.
Yeah, I find a lot of lifters, it's really interesting to watch. I find a lot of lifters that could probably squat more than they actually could squat in the legs, but their trunk muscles just aren't developed well enough. Right. So if you're driving trunk strength through the squat and also the deadlift, they complement each other. So as they'll hit a wall on their squat and it's just because they lose back angle.
Right. Yep.
It's just because they can't hold the back angle where it needs to be, or they get soft in the bottom or something happens there and it shifts the weight forward in their toes or something. And so as we're developing the back musculature in the deadlift, we're developing the back musculature in the squat, and they complement each other and they get stronger faster. But many times it's not that the overall weight is too great for all musculature involved. There's usually a weakness in an area.
Exactly.
And a lot of times that is in the back.
Yeah, that's and so this goes hand in hand with that technique error that I mentioned earlier. I've seen this a lot lately. I don't know if it's just me or if I'm just seeing it more lately.
It's just
but you. When someone's deadlifting, probably is just me. Yeah. When someone's deadlifting, they'll get set up in the nice position because we're coaching them well.
Yeah.
And right when the barbell's about at their kneecap, they start to raise up or try to stand up or lift their chest too early.
Yeah, sure.
And they end up pulling from the lumbar. Right. For the spinal erectors are trying to allow them to stand up, as opposed to continuing to drive their feet through the floor, push the floor away, and continue to use hip extension with their hamstrings and their glutes.
Yeah.
Right. And what happens is the barbell, their shoulders get right above the barbell and maybe even behind the barbell. And at best, at that point, the bar is slightly above the knee. At best, they can maybe
starts to drift forward.
They start to hinge it up, right? So they try to they try to hitch it up if they can, and oftentimes they just lose the lift. And I'll see lifters that have a sharp pain in their lower back when they do that, when they stand up.
They lose angle.
They lose their back angle. They lose their leverage in the bar. They've taken their posterior chain out of the lift. And so that's one thing to look for. If you're getting pain in the middle of the deadlift, then watch your video from the side. Take a video from the side. Look at your shoulder position. If your shoulders are above the bar or behind the bar, you have tried to stand up too fast,
Right.
and you're trying to lift from the lower
If it's
back.
at your knees and your shoulders are behind the bar towards your butt, you're way too vertical.
Way too vertical.
You're way too vertical. Generally speaking, some trunk, some difference in it, body morphology might change that a little bit, but I would say generally speaking,
right about the knee. So if you see yourself doing that, an easy way to fix that back pain might simply be learn how to keep your shoulders in front of the bar as long as you can.
Well, and that's where the beauty of the
Lean over the
RDL
bar.
comes in.
Yeah, right.
Because you can RDL and you're eccentrically using your hamstrings, creating better control, but you're also teaching those back musculature to stay nice and tight and rigid, like a straight lever or a rigid lever. I always tell people there's three things that predicate or control or influence human movement. Always three things. Number one, learned movement patterns. Neurologically, has your brain learned how to do the movement? Number two, weakness or strength. Do you have enough force production or not enough? In other words, are you weak or strong? And then number three, flexibility. How much flexibility do you have in the joint, in the region, to then be able to influence mobility? Because remember, we've talked about in the past that flexibility and mobility are two different things. Flexibility is the inert movement range of motion of a joint or the stretch of a tissue and how far it will excurse, how far it will go.
Right.
Mobility is taking whatever your available flexibility and strength and weakness is, and how can you move that joint now functionally in the real world.
Right. You could have perfectly normal flexibility, but be very weak and therefore have no mobility.
That's right. Yeah, have limited mobility, right.
When people can't squat all the way to depth, right? A lot of times,
weakness.
This is like day one. Yeah, it's not a mobility.
Right.
Well, it is a mobility problem. It's not a flexibility problem.
Issue. That's right.
It's just weakness, so they have no mobility.
So as a coach, and especially when I'm in clinic, I'm seeking to always. I was having this conversation with an intern yesterday at one of our clinics.
Yeah,
I'm always seeking to find out what is the limiting factor in their movement quality or in their ability to move or not move and produce good movement and to be stable. Because a joint that's weak is unstable. A joint that's unflexible is too stable. You can have someone that's really, really strong, but they lack flexibility, and the joint is too stable for movement. I've got to free up some of that mobility. I've got to free up some of that joint movement. So same thing with the spine, but in general, and this is a generalization, in general, in most exercise that we're doing under load with the spine is to be used as a rigid lever. It's to be held straight in a slight amount of extension. And so I don't want to have someone at the top of a deadlift or in the middle of a deadlift go from a lumbar extended posture to a flexed posture and then back to an extended posture under load.
Right.
Now, you might say, well, what about all the Polish lifters, Bulgarian lifters, all those guys that they lift with a kyphotic flexed spine throughout the whole lift? Yeah, they start there and they finish there pretty much.
Yeah, and it's exactly. It's
and they've got
thoracic.
That's right. And they've also got thickened ligaments, connective tissue, and musculature to stack on top of all those structural elements, the disc and the spine and all those tissues underneath.
Right.
I mean, there's years of lifting like that.
Yeah.
And so it's a different recipe for movement.
Yeah, I've noticed like when I pull heavy now, and I didn't notice this like
Polish guy.
2 years ago. Well, sometimes I'll have some thoracic
when you're
flexion.
Pulling like 900.
Yeah, when I'm well, it's a 750. Guys. When I'm pulling the sevens.
Yeah, you get a little bit of flexion.
But yeah, a little bit of flexion happen. But as you get experience and as you get stronger, you can feel each segment of your back staying extended, and you feel just the thoracic start to flex a little bit. But my cue is, as I'm deadlifting heavy, as long as I'm keeping my lumbar spine and sort of my lats are still engaged, my mid back, I can lose a little bit of extension in the thoracic, and that's okay. But I can feel each of those areas, so I've got a lot of proprioception, and I know if I start to lose my lumbar spine and I feel that going to flexion, I put the weight down because I'm not going to grind through that.
Yeah, so I mean, we're talking about this idea that proprioception is the key in all of these things, and being able to use your back as a straight lever is important. The other thing I like to do in exercise selection, a little change here, little shifting gears is sometimes I have patients that their back is a little irritated, a little wonky. Maybe they've got some stenosis, some arthritis in their back, and their back just can't tolerate squatting and squatting, 3 times a week, deadlifting a couple times a week, alternating to one time, or based on what the programming is. It varies from client to client. So I'll try to do some leg driving type strength exercises that will unload the back some. And we have an inverted leg press. I love the inverted leg press for the client that has a little bit of, just back wear and tear. And when you just step them up to 3, even heavy, light, medium, or Texas method, whatever you're doing with them, they just can't do 3 days a week of squatting and deadlifts and assistive exercises and still not feel like their back's a little beat up.
Right.
And so I do that. I will do the leg press usually every other week, once a week. I'll do the leg press. It's just a way to drive some leg growth and drive some leg strength, development, but at the same time, take my back out of it and give my back a little rest.
Right.
Now, the important thing you got to do with the leg press is to ensure that at the bottom of the range of motion of the leg press, when you come into hip and knee flexion and ankle dorsiflexion, that you're not allowing your pelvis to round into flexion too much, because even though you're not putting a vertical load on that spine, you are putting a translational or kind of you're putting what would be called a transverse load on your spine. And so you want to limit that as much as possible, because that can kind of make your back a little angry too.
Yeah, and what you're talking about is when you see that somebody that goes too deep in a leg press, you see their butt kind of come off of the bench a little bit. Some people that are less flexible in that situation
so
might have that.
You're basically stretching the lumbar spine under load in flexion.
Right.
Which is not good.
Exactly. It's not under compression like it would be in a squat, but it's still, it's not
so
good.
I have to really, really focus on driving my back into the mat. And the way I do that is I really focus on, when I'm coming down, keeping that big chest and keeping that abdominal wall tight and pulling with my hip flexors a little bit more in the bottom and drawing that weight down as low as I can.
Pulling yourself into the support.
Right.
Yeah,
exactly.
Yeah, that makes sense.
And so instead of letting the weight drive me into that, I pull myself into that. But I like the leg press because we still get to drive leg growth, like I said, but at the same time, take a little load off the back.
It's kind of nice because it seems like you can do the leg press for more volume, so maybe like sets of 8 or 10, and that's nice. You get a little bit more maybe hypertrophic effect from that.
Sure, get a little bit more size development in the legs.
Yeah, I've got 2 guys that actually I've got 3 guys that all have a history of back pain for various reasons. 2 of them have some nerve root compression, and you've looked at both of them. They've had to lay off training in the past a couple of times due to just some acute pain. Stenosis is a factor there as well. And they're a prime example of what you're talking about. They seem to tolerate squatting max 2 times a week, and we really try to moderate the number of reps that they're accumulating under load at high intensity. So when I have them do their heaviest squats, it's usually for sets of 3, because they can really focus on having great technique and not have a sketchy rep 4 or 5.
Right.
And we'll save the 5s for a lighter day where we're accumulating a little bit more volume. Now, one of those guys, just the way he's built, he's very horizontal in his squat.
Right.
And for that reason, he's got a lot of moment force on his back.
Right.
And that plus the compressive force at the top of the squat, it just really pisses off that stenosis that he's already got. And so what I've done with him is I've actually made his heavy squat be a low bar back squat, and we'll alternate some in the middle of the week. We'll do the leg press to take the compression force off of his spine, and then for his 3rd leg slot of the week, I've been having him do a front squat. Right. So he's much more vertical, so he doesn't have quite so much moment on his lower back, along his spine.
Yeah.
And that seems to work well. And what it does is, this is something we talked about with the shoulders as well. It allows him to make the movement harder without actually using more weight on the bar. Right. So there's less compressive force on his spine, because the weight's lighter, but it's still a more difficult
mechanical
movement.
Advantage too.
Exactly.
So it's producing more. He has to produce more force because of the position of the load. So yeah, a lot of those guys that have those stenotic conditions where there's a little less disc height, then they got a little bit less margin for error. And stenosis is basically a closing of an area, a narrowing of an area. When we're talking about foraminal stenosis, foramens are the holes that the spinal column has a central canal foramen. The lateral foramens or the neural foramens are where the nerve roots exit. So they're little holes that are created by bones. Sometimes they're created by two bones that meet in the middle and they create a circular opening or ovoid opening. But with clients that have stenosis, there's a narrowing of those recesses or a narrowing of those canals. And so I find that those patients will do well in the bottom of the squat. They'll do well in the bottom of the deadlift. And sometimes they'll get a little pain at the top of the movement when they go to unrack or when they go to finish the lift, like in a deadlift at the top, or when they go to finish sometimes at the very bottom, because it's a load-unload of that indicated area. And there's greater compression when there's more vertical load on the spine, like it's standing up straight or unloading.
Top.
Yeah, at the very top.
Right.
And so sometimes we'll modify that movement. We might shorten the range on the deadlift, pull from a little bit higher off the floor. Sometimes on the squat, what I want to make sure that they're not doing is overextending at the top. I like for them to stay under the bar a little bit longer before they stand up and just, for lack of better terms, give that time a little bit of time to decompress a little bit. It's the same philosophy I have when I do lumbar traction in our clinics. I don't do lumbar traction on a patient's lumbar spine in the clinic and then have them sit right up when I take the poundage off.
Right.
I give them about 5 minutes to just kind of reset.
Right.
And relax. And they do a lot better with it too. So you don't have to do 5 minutes on a squat or a deadlift, but just give yourself a little chance before you stand back up or you get out from under the rack. Relax your back, let your back unload a little bit and see if that helps.
Yeah. So you mentioned something there in passing that I think is really important. This is another form thing that I see often when people complain of back pain is overextending at the top of the squat. And you'll see this with guys sometimes. They'll try to create tightness in their back and they'll try to extend their back by shoving their belly forward. And maybe overdoing the, sometimes we'll say proud chest or
instead of just opening
chest.
the hip.
Right.
The hip is where you extend.
And what happens, yeah, exactly, right. And what happens is they lose tightness in their abdominal wall. You can do this at home, just standing up or sitting upright, is if you try to shove your chest out real hard and you create a lot of thoracic extension, it'll feel like your upper back's tight. But you actually, if you overdo it, your abs get loose. And then if you come back to neutral, your abs get a little bit tighter. And so it's actually very difficult to create abdominal tightness and create a whole bunch of thoracic extension by shoving your chest out. That's not what we mean. So what I'll often have, if I see that happening and somebody's getting back pain in the bottom of the squat, then what I'll have them do is learn where the neutral point is in the squat. So I'll have them unrack their squat, take a big breath, and then do a little crunch downward to make sure that they're really feeling where their abs are engaged. Sometimes if they're having trouble getting this, I'll just take them aside off the barbell outside the rack and just have them do that a couple times. Like, here's overextension, here's what you're doing. Now do a crunch. That's neutral. Right. Your back is neutral or slightly extended. Now it's not overextended. So watch out for that.
Yeah. And I think that it's hard to get clients sometimes to when they're pulling to the top on a deadlift, to get them to if like you said, if they're trying to get full extension and get the bar, their shoulders slightly behind the bar at the top and the hip at the top of the movement, but they're not fully opening the hip. So like in a lifting, when we do a lifting meet, one of the judging things that I'll ding someone on is if they're not standing fully upright.
Yeah,
they're overarching their upper back and letting their back get soft into extension, not flexion, but in extension to get the full lockout. I want to see their hip open up all the way too. So the way you do that is to tighten your butt cheeks really hard and slightly shove your pelvis forward. Okay, now I don't mean lean back. instead of lean back, shove your pelvis forward. Think pelvis forward, butt cheeks tight, lock the knees out. That will help.
Yeah.
And a lot of times guys are just really tight in the hip flexors, and that will help to stretch those hip flexors out under the load too. So
definitely.
So that's just a good point there. So we have all these different programming modifications and exercise selection modifications that we can make with low back pain. The important thing to recognize, though, is that not all low back pain or low back injuries are the same.
Right.
So this does require, and I hate to say this, and I'm not trying to sell our service or any other coach's service, but a learned coach with some background in training clients with low back pain is very, very important, because in a lot of these cases, how we change things, it just matters.
100%. It depends.
Well, it matters what it is.
And what a coach can do for you is ensure that you've got the technique piece of this locked down. Because if your technique is bad, then that has to be fixed first before we can really evaluate if there's something, if there's really a pattern there.
Right.
And sometimes you have to fix the problem and stay with that fix for a few weeks for it to work itself out. If you're continuing to get pain after you fix the problem, though, that's when you fixed any technique issues. That's when you might want to bring in, your doctor or a physical therapist and maybe go get an MRI and see if you've got something else going on. So you have to be able to separate all these things, and that can be difficult on your own. If you just can't see the form errors you might be making, go get a coach at least for a session. Make sure you're doing it right, and then if you're still not if you're still experiencing pain, that's when you might want to go to the doctor. And
the other thing is, I want you to recognize too that a lot of times the way people self-treat this or other medical providers treat this is avoidance.
Yeah.
They just basically say, don't lift, don't run, don't do whatever you're doing in your life that you enjoy to do. I don't take that same philosophy, and I don't think that's a recipe for success. That it doesn't take a rocket scientist to say, if that hurts, don't do that.
Right.
But that might not that's a very easy way out in my book. I want to try to create I want to try to facilitate a creative solution for the client, whether they be a strength client or a patient. And so, like what I said to a client yesterday, my buddy who came in to see me as a PT patient, I basically told him, you have a choice here. You can get stronger, and you may eventually have to have a lumbar surgery to get this sequestered extruded disc out of there if it continues to be a pain problem, and you're going to be stronger. But we're going to lift you and do exercises, assistive and accessory exercises correctly, so that you have a reasonable chance for success with exposure to proper strengthening and lifting and spinal mechanics without danger.
Right.
That's the key. Exposure to training aids and improvement without danger. Or I guarantee you will revisit that same back injury again, and they only generally get worse. They only progressively get worse over time. They seem to ramp up over time because the pathology is getting a little bit worse each time. And then there's also the behavioral aspect that goes to it. And so we live with this avoidance type behavior. That's not an appropriate way to manage this. The appropriate way to manage this is with our minds and to use intellect and proper experience and training and observation to try to intervene with appropriate stressors to get people down the road.
Right.
And that's the key. So if you're dancing around a back problem, if you've decided you don't lift weights anymore because you've got back pain, that's okay. You're going to have back pain.
Right.
And the question is, what kind of quality of life do you want?
Yeah. Do you want to have back pain and a weak back and not be able to move around? Or do you want back pain and a strong back?
Yeah.
And probably less back pain.
Well, absolutely. And I say this to my client base in my clinics and in their gym all the time. 9 times out of 10, people are not using their backs correctly. They're not training correctly. And when they just get a little bit of advice or a little bit of experience from someone who has a background in this, someone who has treated hundreds and thousands of clients with these problems, then all of a sudden they can move forward. And it wasn't the exercise. It's not good exercise that's causing their back pain. It's many times other things.
That's right.
Bad exercise.
Yeah, I was about to say
lifestyle habits.
That's like the doctor thing, right? Is like, we'll stop doing that. Lay off the lifting. Well, it's like you don't get to lift incorrectly and then blame the lifting for your problem.
Right. Exactly. Yeah. And then I will say this: there are those clients that we can't just go back to lifting even with proper form sometimes.
Right.
We've got to intervene with some other type of medical intervention, and then we can get them back to the gym. That's the goal. But hey, guys, thanks for joining us. This is a long podcast, and we could continue to have this conversation just ongoingly about low back pain and training and how we modify things. I hope what you're getting, the overarching theme here is, don't avoid getting stronger. Don't avoid lifting because you have back pain.
Right.
Number 2, find a coach that you can modify your program, modify your training, your exercise selection, but make sure that it's well thought out, and then there's a lot of experience and there's a lot of science behind, the best science that we have in doing it. And then number 3, also recognize that a strong back hurts less.
Yeah.
A strong back hurts less. And so you have anything
I'll
else?
say, I'll add a number 4 there. Approach these things with an inquisitive mindset. I think it's good for your emotional state to kind of step outside yourself for a second and observe what's happening and describe it, rather than being like, oh God, that hurts. Oh my gosh, right there. Oh, it's so tight. Oh, it hurts. I got to go sit down.
Right.
That would be catastrophizing the incident. Instead, take a moment, take a few deep breaths, walk around if you need to, and then try to step outside yourself. Okay, like, where did I feel that? Did I feel at the bottom or the top? Did I feel it when I unracked it or when I racked it? Where exactly is it? Not just my lower back hurts or my back hurts. Like, where is it? Lower, right? Try to be specific. And I think not only will that help your coach when you engage a coach to help you, but it also kind of helps you find your own patterns and start to think about this logically rather than getting too wrapped up in the emotion of it.
Yeah, learn your machine. Body awareness goes a long way.
Yeah.
So, hey guys, thanks for joining 40 Fit Radio, and thanks for joining the 40 Fit Nation. You can email us, info@40fit.com. Check us out on Instagram @40Fit Radio. Trent is @Marmalade Cream. I'm @DR Deaton. You can also go to the Facebook page, the 40 Fit Nation. So great to have you guys today. Have a safe and healthy and happy rest of the week, and go out there and get strong.
Adios.